Welcome everyone. This Sunday evening, the best is Beat Epilepsy, Stay Informed series of webinars, and this is the 7th in the series. So we've been at it for the last 7 months, and this is by no means, by all means, a very significant webinar, for the reason that this webinar is being hosted by the Tirupati chapter of the Indian Epilepsy Association, and as you all know very well, the Dr. Vengamma, the president of the Indian Epilepsy Association. So it is the president's webinar. So I think it is extremely important and significant. We have, of course, a galaxy of important people in the Indian Epilepsy Association and the Indian Epilepsy Society. We have the President-elect Professor Satish Chandra from Bangalore. We have Professor Mendirata, who is the past president of the Indian Epilepsy Association and the current president of the Indian Epilepsy Society. Dr. Manjari Tirupati is the secretary of the Indian Epilepsy Society. There are others, Dr. Chanda Kulkarni from Bangalore, and Dr. Surekha is also there. Dr. Surekha is the treasurer of the Indian Epilepsy Association. So welcome everyone. I have not introduced or taken the names of the local attendees from Tirupati because I think the pleasure of introducing the local participants for today's webinar would be Dr. Vengamma. So it is customary that the president, Professor Vengamma, usually says a few words to inaugurate and set in motion the proceedings of the webinar. But today, Dr. Vengamma would not only be inaugurating the webinar, but it is her own webinar. She is the host for the webinar today. She is the organizer for the webinar today. So I'm sure it is going to be highly successful and extremely useful for all of us, including all the attendees in today's webinar. So yes, a couple of housekeeping announcements. The first of it is that we would want this webinar to be very interactive, so questions are always most welcome, as also the feedback. But please try to make sure that there are no personal questions or individual treatment related questions which are difficult to answer in a setting like this. The other thing is, at the end of it, there is always a feedback, and please, your feedback is extremely important, and it guides further, how to reshape of further programs of the Indian Epilepsy Association. So that's extremely important. And of course, all those who are attending, I'm sure they're already members of the Indian Epilepsy Association, but if there is someone who's not a member of the Indian Epilepsy Association, then we would request and strongly recommend that he or she should become a member of the Indian Epilepsy Association. And in this particular slide, we have listed all the important benefits and the modalities of becoming members of the Indian Epilepsy Association. So with this, I would hand over the room to Professor Vengamma and to say a few words to introduce and the theme for today's webinar, as also the participants for today's webinar. Thank you.
Good evening, Dr. Gagandeep Singh, Secretary of IEA. I'm really very happy to host today's series of webinars on BEST, that is Beat Epilepsy, Stay Informed, the 7th series, as a part of our 50th anniversary celebrations of Indian Epilepsy Association. And as all of you know, that from August 2021, we initiated this on August 15th, that is third Sunday. continuously, uninterruptedly, we are doing the programs. The first program was organized by Ludhiana chapter of IEA Punjab from Punjab. Most important topic was medication adherence. The next month, Mumbai chapter, that is Saman Group, has organized very another important chapter, that is topic, that's precipitating factors for epilepsy. And October 2021, the Bangalore chapter of IEA organized another important topic, that is epilepsy and driving. In November 2021, the Secunderabad chapter of IEA organized epilepsy in children with behavioral and cognitive issues. And in December, IEA Jaipur chapter has organized epilepsy in women and their own issues. And in January 2022, the Delhi chapter has organized something called Empowering Person with Epilepsy, Live Your Best Life. And then in February, because as a part of celebrations of International Epilepsy Day across the country by all the chapters, we didn't have a webinar series because every second Monday of February is a part of International Epilepsy Day celebration. Each chapter did quite many activities, and it is worth noting that Dr. Gagandeep has taken a good initiative in organizing the NDTV program, as well as all the local chapters have done their own, in their own way, spreading the message across the epilepsy, what we could see through print and electronic media. And today, March, the Tirupati chapter has taken initiative to host the 7th series of webinar. The topic chosen was epilepsy in elderly, because this is also equally important, as all of you know, that there is a increase in the lifespan of the individual, life expectancy of the individuals. There is a growing population is becoming more and more, and elderly also constitute quite a much of the population. And the management of epilepsy in elderly is equally important and different, like epilepsy in pediatrics. And we, Tirupati branch, have taken this topic for the discussion. And we have neurology, psychiatry, and specialty from geriatrics in our panelist. To moderate that, our professor, Dr. Alladi Mohan, who is the senior grade professor of internal medicine at Sri Venkateswara Institute of Medical Sciences, has taken initiative to be the moderator to have this today's webinar on epilepsy in elderly. I request to Dr. Alladi Mohan to introduce all the panelists, and I once again welcome all the members of IEA, Professor Mahendra Datta, past president of IEA and current president of IES, Professor Satish Chandra, president-elect of IEA, Professor Manjari Tripathi, secretary of IES, Dr. Rajendra Surekha, our treasurer of IEA, and other governing council members. And I welcome and thank all my own faculty of neurology, psychiatry, and geriatrician who have taken their initiative in being the active participant in this today's panel discussion on epilepsy in elderly. And over to Dr. Alladi Mohan.
Namaste everyone. Good evening, madam. At the outset, it's a great occasion for all of us to be together today on the occasion of the President's webinar. Our panelists today include the esteemed President of the IEA, Dr. Vengamma. We also have on the panel today Professor Nandagopal, Professor of Neurology at the Institute. Hello, Professor Nandagopal. We have Dr. Naveen Prasad, who is Associate Professor, Department of Neurology at the Sri Venkateswara Institute of Medical Sciences. Dr. Nandagopal. and Dr. Naveen Prasad or with Professor Vengamma here. Hello, Dr. Naveen Prasad.
Good evening, sir. Hi, sir. Good evening, sir.
From the institute, we also have from the Department of Psychiatry, Dr. Ganesh Kumar.
Good evening, sir.
He's an assistant professor in the Department of Psychiatry. Hello, Dr. Ganesh.
Good
We
evening.
have on board as a panelist Dr. Manisha, who is the geriatrician from the Department of Geriatrics, the Nizam's Institute of Medical Sciences at Hyderabad. Hello, Dr. Manisha.
Good evening.
I am Ladi Mohan. I am a senior grade professor of internal medicine. I am the Dean of Sri Venkateswara Institute of Medical Sciences, Tirupati. Respected and esteemed Dr. Gagandeep Singh, Dr. Manjari Tripathi, Dr. Mendiratha, Professor Satish Chandra, and other esteemed governing council members of the IEA and the IES. Welcome once again for the colorful post-Holy weekend for the webinar on epilepsy and the elderly. So we get going straight away with Professor Vengamma. Madam, the topic is intriguing, epilepsy in the elderly. It would be very nice if you could elaborate as to why epilepsy in the elderly is an issue to contend with, and it is a problem of significance. Yes, madam.
Thank you, Dr. Mohan. As all of you know that elderly is a heterogeneous group, and now there is a progressive increase in life expectancy, because of which elderly persons constitute the fastest growing segment. And most important, the challenges we face in terms of diagnosis and treatment in elderly because of varied and atypical clinical presentation. And then etiology is definitely different compared to the younger people and children. And these elderly people have an associated lot of comorbidities like diabetes, hypertension, and other cardiovascular diseases, which have posed challenges in the management. Another thing, they have most important, elderly people have a cognitive difficulties in significant proportion of patients, which will again have a problems, gives a challenges in the diagnosis and treatment. And while therapeutic challenges, because of the age, there are a lot of physiological changes like pharmacodynamics and pharmacokinetics of the drugs in elderly also different. That's why this epilepsy in elderly is an unique situation. That's why we choose this topic for discussion today.
Thank you, madam. When we had planned this webinar, discussion started with what exactly is elderly? How old one has to be called elderly? Because we build a building based on the bricks. Dr. Manisha, as a geriatrician, in your field, how do you define the old or the elderly?
There is no standard definition to say an older adult or geriatric age group, but however, traditionally, it is defined in terms of chronological age. Older adults are considered into three distinct groups, which consist of young, old, and very old. The young old consist of individuals between 65 to 70, between 65 and 74 years. The older adults constitute people between 75 and 84 years, and the very old adults include people who are above the age of 85 years. However, older people are a very heterogeneous group, and each person, each individual is different from each other. Thank you.
Thank you, Dr. Manisha. As it is mentioned in the Yajurveda, Vruddhanchame Vruddhischame, older and growth. The other point to contend with to begin is is epilepsy the same in the elderly as it is in other age groups? In other words, how do you define epilepsy in the elderly? This question goes to Professor Nandagopal. Sir, could you please elaborate?
Okay, am I audible?
Loud and
Yes.
clear.
Okay, thank you, thank you. So, so sculpting this term epilepsy from the title, let me just try to paint the picture of what constitutes epilepsy. The term epilepsy, if you look at the root word, etymologically, epilepsy, epi means upon, lepsy means take hold of, basically it is derived from the word seizure. So let us look at what constitutes a seizure. Seizure is a discrete event or an episode which is because of abnormal electrical disturbances in the brain. That means the brain circuits are overexcited and hypersynchronous, giving rise to various experiences. And the discrete event is called seizure. Now, if you have more than 2 unprovoked seizures that are separated more than 24 hours, that would constitute epilepsy. But if you have only 1 unprovoked seizure, but if there is a high risk of getting further seizure to the tune of more than 60%, then that also constitutes the definition of epilepsy. This includes certain groups of patients, for example, patients with new onset seizure, first time seizure, but with a remote lesion like prior stroke or prior head injury, prior brain infection, prior anoxic brain damage, etc., etc. So, and the third one is if you have defined epileptic syndrome, that if you recognize in the patient, that also constitutes the definition of epilepsy. Thank you.
Thank you, sir. Now, how big is the problem? What is the burden of epilepsy in the elderly is another fundamental issue which forms the basis for the discussion in the panel discussion today. Dr. Naveen Prasad, could you please explain in greater detail regarding what is the burden of epilepsy in the elderly?
Good evening, sir. Sir, as per the statistics of World Health Organization, every year around 39 people per 1 lakh population in high income countries and around 140 people per 1 lakh population in low and middle income countries like ours suffer epilepsy. The incidence of epilepsy in elderly increases as the age increases after 50 years. And the individuals with age greater than 75 years are at highest risk of developing epilepsy. Coming to the estimates of number of people who are having active epilepsy in the population, which is given by the prevalence rates, it is estimated around 0.4 to 1% of the population are at risk or will have the epilepsies. Then when it comes to the elderly, the prevalence rates of epilepsy is around 5 to 6%, which means the elderly people are at 5 to 6 times more risk of developing epilepsy, sir.
Thank you, Dr. Naveen Prasad. The psychiatric problems frequently coexist in the elderly. These have a bearing not only on the diagnosis, but also on the treatment of epilepsy. Dr. Ganesh, from a psychiatry point of view, can you throw some light on these?
Sure, sir. As you said, sir, may I audible, sir?
Yeah, you are loud and clear.
So, yes. As you said like that, around 30 to 50% of psychiatric comorbidity is seen with epilepsy, chronic patients suffering with epilepsy. And there is a hypothesis, and the epilepsy and psychiatric comorbidities are bidirectionally related. In previous decades, they used to think that epilepsy and psychosis would occur together, or maybe it's a kind of chicken and egg situation. So it was so confused at that time. But however, recently population-based studies, they are saying that patients who had pre-existent major depressive disorder and bipolar affective disorder and multiple episodes of suicides, they are having more risk to develop epilepsy in the future. So it indicates that some psychiatric disorders, that major mental disorders, so they are having this predisposition to give rise to epilepsy. So this is very important to note down. And on the other hand, as I said, 30 to 50% are associated with psychiatric comorbidities who has already been suffering with the psychiatric, epilepsy. And apart from that, the epilepsy, I mean, psychiatric comorbidity is more commonly seen with CPS, complex partial seizures, and temporal lobe epilepsy. This is more important. When it comes to elderly patients who are suffering with epilepsy, their study says that drug use, and most commonly depression and drug use, are contributing to the psychiatric comorbidity. And last thing is how they are relating to each other. They are relating to each other in terms of prognosis is very important. So like that, when we miss the diagnosis of treatment, when we are not able to give the treatment for the depression, there might be a risk that the patients may get into treatment resistant epilepsy. So this is very important to diagnose and treat the psychiatric comorbidities.
Thank you, Dr. Ganesh. Looks like the problem of epilepsy in the elderly is like the elephant in the room. It's around, but hardly looked at in detail. So it's now time to move ahead with the next issue for discussion, which is the diagnosis of epilepsy in the elderly. Professor Vengamma, Madam, the diagnosis of epilepsy in the elderly is considered to be a challenge. Could you elaborate why?
Diagnostic approach in elderly is almost same as in younger patients, but most important is the detailed history to be obtained from not only from the patient, but also either from the caregiver or the eyewitness. Here, because of elderly people, most of them, they stay alone. There may not be a proper eyewitness account to confirm the history. In addition to that, most of the elderly people will have a cognitive impairment. That's why they'll not be able to tell much about the history component. That's why here it poses a little more challenge. But now, at least most of the time, the diagnosis depends upon the history, as well as now with the mobile recording of the attack. Because sometimes even if the eyewitness is there, in their anxiety, they may not notice all the events. Now, for the last 2 decades, I think once these mobiles have come, we always ask them to get a video of the recording while patient is having attack. By looking at that, we may be able to diagnosis this patient. Most important, like first thing you have to check after the history and examination. First, you have to check whether it is a seizure or a non-epileptic event. There are many things which can mimic at this age, like suppose due to syncope, secondary to cardiovascular problems, or a carotid sinus syncope, or they can have a transient ischemic attack secondary to vascular diseases or a transient global amnesia, or sometimes in the sleep, they may, like REM sleep behavioral disorders can be there in elderly because of other neurodegenerative diseases like Parkinsonism. All these mimics can sometimes are mistaken for the diagnosis of epilepsy in elderly. That's why most of the time it is observed that there are either missed diagnosis or underdiagnosis, or there could be a overdiagnosis. Sometimes any involuntary movements of any of those neurodegenerative diseases, or sometimes limb shaking, TIAs, all those things are mistaken and thought of a seizure. I think here there is a patient-related factor, because patient being staying alone and because of cognitive, the history may be little inadequate. Sometimes physician-related, may not have an adequate knowledge about the non-epileptiform events, and as well as sometimes TIS, there may be a chance of overdiagnosis and underdiagnosis is very common. But one thing is sure, like even if it is a single seizure, you have to check is it is a provoked or unprovoked seizure. If it is a provoked secondary to cause, we have to check it. Otherwise, if it is an unprovoked seizure, you have to start and get an investigation to find out the cause. Here, the diagnostic approach definitely differs compared to children and adult, because underlying structural cause, etiological causes are very more. That's why the history and definite neurological examination will definitely show some signs to have a focal deficits. Then investigations to know the underlying cause, and most important also to exclude other seizure mimics to avoid underdiagnosis and overdiagnosis.
Thank you, madam. It's very rightly put across that epilepsy in the elderly can be a misdiagnosis, or even a misdiagnosis. With this background, I'd like to ask Dr. Manisha, as a geriatrician, how do you see the presentation of epilepsy in the elderly? Is it same, different from what you see in other adult patients?
The presentation is usually different. And it also, the diagnosis is difficult because the presentation is atypical, which means the older adults do not necessarily present with the motor features like tonic-clonic seizures or focal seizures. They might usually present with episodic confusion, drowsiness, clumsiness, without any motor features, and aura might not be there in all the elderly people. Also, they have prolonged post-ictal states, especially in patients with previous history of brain dysfunction, that is stroke and dementia. So all these things make the diagnosis a bit difficult in the elderly people. So these are the usual differences from the presentation from the younger adults.
Indeed, the presentation of epilepsy in the elderly seems to have its own dimension. Dr. Naveen Prasad, as a neurologist, you do encounter elderly presenting with epilepsy to you. So what is the neurologist's perspective of the clinical presentation of epilepsy in the elderly? Would you share your thoughts, please?
Thank you, sir. Thank you for that question. When compared to younger individuals, the fits or seizures in elderly commonly take its origin in one half of the brain. Say it is called a focal seizure, which can have manifestations seen or felt over the limited parts of the body. Say, for example, they can have turning of eyes for a moment of time, blinking of eyelids, or stiffness or repeated movements involving one hand or leg, or sometimes transient episodes of confusion. These focal types of seizures in elderly have few peculiar features in that they have less frequently associated aura, which means the pre-seizure subjective warning signs that a patient with epilepsy experiences, and they have less frequent automatisms, which means the motor mannerisms or peculiar movements that are commonly associated with this focal type of seizures. And they can have manifestations like transient episodes of confusion lasting for a brief period of time, which can be confused as a confusional episodes in elderly. And the other peculiar aspect of the focal seizures in elderly is post-episodic confusion, which may last up to hours to 2 weeks, which can really pose challenges for correct diagnosis in elderly.
Thank you, Dr. Naveen. Now, there has been a lot of focus on the atypical presentation, quote unquote, of epilepsy in the elderly. How typical is atypical? Professor Nandagopal, could you please elaborate on this?
Am I audible?
Yeah, loud and clear.
Okay, thank you. Like, so we have covered some of the typical clinical features of seizures in the elderly. Now moving on to the atypical features, like, so what we need to remember is any experiences in the brain, be it motor or non-motor, that includes sensory, autonomic, cognitive, psychic, or emotional, features could be an expression of epileptic episode. For example, in the motor manifestations, there could be atypical features such as sudden unexplained fall, like the atonic seizure or akinetic seizure. But before making a diagnosis of akinetic or atonic seizure for an unexplained or repetitive falls, we need to exclude syncope and vestibular problems, that the inner ear apparatus controlling the balance in the elderly. And then there could be other manifestation. For instance, a person admitted for underlying neurological problems such as stroke and other etiology. In such a situation, sometimes you could see unexplained or unknown cause of altered mental status of coma. In other words, the stroke may be not that much severe. They may be disproportionately impaired altered mental status. So in such a situation, there could be a possibility of seizure or so-called non-convulsive status epilepticus as an underlying or potential reason for the altered mental status. And sometimes the person could have a kind of atypical features such as dystonic seizure, for example, fatiobrachial dystonic seizures. This could happen very briefly, like lasting for a few seconds, but multiple times in a day, maybe up to 40 times or 50 times in a day. And if you recognize that, could be a useful clue for underlying autoimmune encephalitis related to LGI1, like leucine-rich diamine-activated protein 1, that sort of thing. Like, so that kind of condition could be imminently treatable with immunotherapy. And also, we could have some other peculiar situation. One is the previous speaker I already spoke about, like the limb shaking TAA that could cause some confusion with seizures and all. That happens in patients with the limb shaking TAA may have a high-grade corrective stenosis. And typically when the patients has a change in position, especially in the stand-up, they may have episodes of limb shaking or tremulousness of the limbs. And that could be mistaken for seizures. But on the other hand, there is a peculiar feature, something called amyloid spill. Like patients who had amyloid deposition in the blood vessels of the brain, they may have leaky blood vessels, and sometimes you get some hemorrhages in the subarachnoid space in the convexity of the brain. And these can give rise to brief frosting episodes. Sometimes there could be negative symptoms such as weakness, loss of speech, etc. Sometimes they could have positive manifestations. And we have seen sometimes in those situations, whatever investigation we do may not reveal, like EEG and other electrophysiological tests may not reveal, or could be non-specific. And the imaging could show some focal hemorrhages, like so-called focal cortical siderosis, microbleeds, etc. That could be useful clue for the diagnosis. And when we treat with anticonvulsants, some of these episodes may disappear. So these are some of the peculiarities in this setting.
Thank you, sir. That's very well, crystal clear explanation on the atypical presentations. Adult patients with epilepsy choose to consult a physician, a geriatrician, more importantly, a neurologist. In this diagnostic merry-go-round, the availability, acceptability, approachability, and accessibility of the treating doctor also plays a role. So not uncommonly, in this diagnostic merry-go-round, patients with elderly patients with epilepsy consult a psychiatrist. So Dr. Ganesh, from a psychiatric point of view, there are several psychiatric disorders and other conditions that constitute mimics, and they form the important differentials in the laundry list of differential diagnosis of the epilepsy in the elderly. Could you please elaborate on this?
Yes, sir. Yes, sir. There are a lot of differential diagnoses, sir, but the most important one, sir, we should keep in mind while we are evaluating the seizures patient or epilepsy patient. The first and foremost thing is functional neurological symptom disorder, also called functional neurological disorder, and dissociative disorders. We are talking about patients with elderly, so it is common in rehabilitation homes or old age homes. So what is the main important? If we miss the diagnosis, then we can reduce the huge burden I mean, we can avoid if we find the proper diagnosis, we can reduce the huge burden on the patient, like financial, psychosocial burden on the patient. On the other hand, if you can't find the proper diagnosis, maybe the patient will have drastic consequences. That's the importance of that. Apart from that, having said that, there are 20% of patients who has coexistence FND as well as seizures. This is important to note down. And apart from, there are a couple of differential diagnoses. First is panic disorder. In panic disorder, there are certain symptoms which present in ictal state, like anxiety. We may confuse it as panic symptom, and as well as there is a paroxysmal symptoms in psychosis, where the patient laughs and cries. We may miss for the crying seizures, the laughing seizures, something like that. And also there, as Madam said, that there are parasomnias and narcolepsy. Narcolepsy may present with cataplexy, which is a loss of muscle tone, characterized by loss of muscle tone. So we may confuse with atonic seizures. And somnambulism, like parasomnias, we may confuse with automatism. So these are the important things. Apart from that, mental retardation with behavioral problems also we should taken care of while evaluating the epilepsy, because epilepsy is most often associated with genetic syndromes. So this is important. And last but not the least is factious disorder. So here the intentionally production of the physical or psychological symptoms to deceive the identity of the person. So it is also very important. Last thing is malingering, which is not often seen, but which is usually seen in patients who are criminally charged, and they do mimic, like they act like as if they have seizures to avoid the criminal charges. So these are the few differential diagnoses we should be careful when you are evaluating the epilepsy patients.
Thank you, Dr. Ganesh. For every clinician, the first thing that comes to their mind is establishing the diagnosis of epilepsy. So the diagnostic evaluation of epilepsy in general, especially epilepsy in the elderly, is an ordered, structured, and sequential, well-planned workup. Professor Vengamma, Madam, how is epilepsy in the elderly diagnosed?
Epilepsy diagnosis, again to re-emphasize, it is first and foremost is the history, then the examination. Here, the investigation is also equally important to confirm there is an epilepsy, like EEG to rule out non-convulsive epilepsy, non-convulsive status epilepticus or partial seizures. Other important thing is there is a generally metabolic causes also are there. We have to do the blood test. And then most important is the imaging also to be done. But to highlight, it is the clinical history from the caregiver as well as the patient. Then the brief examination which shows signs coming, and the investigations of blood, EEG and imaging will definitely help for the diagnosis as well as for the underlying etiology, to know the underlying etiology.
With this battery of investigations ahead of us, Dr. Manisha, as a geriatrician, can you elaborate on the role of laboratory testing in the diagnosis of epilepsy in the elderly? What kind of testing do you use in the geriatric practice?
Definitely, the diagnosis is made by taking detailed clinical history and physical examination. Also, neuroimaging is the mainstay. However, I would like to do few blood tests to know the cause for the occurrence of the episode. That is, I would like to check the electrolytes, sodium, potassium, calcium, and magnesium, and also the blood glucose level. Because the usual causes, the common causes of a convulsion in an elderly adult could be a result of hyponatremia or hypoglycemia, especially patients who are on anti-diabetic agents or patients who are on any drugs that can result in hyponatremia. Apart from this, I would like to also test the renal functions and the liver functions as a baseline. If at all the diagnosis is established, the baseline renal function and liver function and the full blood count is necessary before starting the treatment. So these are the tests that I would like to do.
Thank you, Dr. Manisha. Then coming to imaging, which is now fairly widely available and accessible across India, Dr. Naveen Prasad, can you elaborate on the utility of diagnostic imaging studies in epilepsy in the elderly? Who needs them? What form of imaging? How frequently, and so on?
Am I audible, sir?
Yes, yes.
Yes. Epilepsy in elderly should be evaluated thoroughly. The emphasis of clinical history and examination and laboratory tests were discussed by the previous panelists. And coming to the imaging, imaging helps in establishing the clues for the cause of the underlying epilepsy. The modalities that are available for us are CT brain and MRI brain. CT comes with the advantage of widely available even in the small towns and can be acquired rapidly, which requires a very less patient cooperation, can be taken up even in the acute settings. It is the best modality to identify bleeds in the brain. But the MRI has the disadvantage of time consuming and requiring patient cooperation to some extent, but it comes with the advantage of better tissue characterization in of brain, especially involving the hindbrain or the small brain. But and also it is very sensitive in picking up of the small clots involving the posterior part of the brain. So in this way, the imaging helps in arriving at a etiological diagnosis of the epilepsy in elderly, sir.
Thank you, Dr. Naveen Prasad. EEG is another tool which the neurologists frequently employ in evaluating their patients. Professor Nandagopal, could you elaborate on the utility of EEG in the diagnosis of epilepsy in the elderly?
Okay, am I audible?
Yes, sir.
Yeah, as we discussed earlier, the epilepsy is a problem with electricity in the brain. Like so, in Arabic they call it as karaba, or maybe in Hindi bijli, something like that. So if it is a problem in the brain, so the person who is treating the seizures, they may be called medical electrician, just like the stroke physician who treats the stroke could be called as a medical plumber, like that. So, but if you have any medical, the electrical circuitry problem in your house, better to call the electrician rather than a neurologist, because the neurologist will come and they will want to lateralize the problem, localize the problem, and they mean some imaging and all to characterize where the lesion, where the lesion is, what the lesion is, etc. Jokes apart, like, so if epilepsy seizure is electrical disturbance in the brain, then catching electrical waves in the brain through some modality could be useful. For instance, when I had some problem with the battery of the ophthalmoscope, which is a rechargeable battery, I took it to our biomedical person, and he used this voltmeter something to check whether there is a flow of electricity. Similarly, if there's an abnormal electrical activity in the brain, so we could just put an electrode on the surface of the skull and we'll try to record. But the problem is the skull acts as a filter, and so we need to amplify the activity and record. So, as I mentioned earlier, in patients who are having atypical manifestation, for example, patients who are in unexplained altered mental status, behavioral problems, emotional problems, or like unexplained brief episodes of fear, anxiety, etc., which are stereotypic. So, in those instances, when we do, when you obtain EEG, especially long-term monitoring and all, like that investigation is very crucial and helpful in unraveling the seizure or non-convulsive status epilepticus as the underlying cause of the clinical manifestation of altered mental status. And apart from that, like when you have a suspicion of syncope, but if you're not very certain, when you do EEG, you may or may not find changes. Like during the syncope, you may see some slowing or suppression of brain waves. But the accompanying ECG in the EEG recording could help us to unravel some arrhythmias or some conduction block, etc. And now, if you have a strong suspicion of seizure, then the yield from the EEG, pickup rate from the EEG could be better if the EEG is done within 24 hours and the patient has more than one episode of seizure, and if the patients have not been started on anticonvulsant. So one message that we need to understand is that, like, relatively normal EEG does not rule out seizure. So basically, the diagnosis of epilepsy seizure is electroclinical syndrome, and we need to put equal emphasis on the clinical feature also. And in the elderly, we could get some lot of non-specific background abnormalities in the ECG. So we need to put things together.
Thank you, sir. Dr. Ganesh, from a psychiatry perspective, how useful are these laboratory investigations, imaging, and EEG in the diagnosis of epilepsy? A quick, short, and sweet response from you.
So in the point of psychiatry, we usually mostly we rely on the history taking. We try to find out the personality, and we try to find out the past history of any psychiatric illness and relations with the family members. And currently, the patient is suffering with any psychiatric disease or not, and we conduct a regular MSCs, not a single mental status examination. We conduct a regular mental status examination, and we will conclude that we will try to differentiate the behavioral abnormalities from the epilepsy. So, psychiatric interview is the be all and end all to differentiate between epilepsy and abnormal behavior. Having said that, there are certain conditions like aggression, catatonia, altered mental status. The patient presented with these conditions, then we have to go for EEG and imaging to find out any unrelated underlying seizures, because they are also manifestations of seizures. And last one is when the patient is having alcohol withdrawals within a span of 2 hours. If he present like status, then we should try to inquire about any organic cause. So this is briefly about that.
Thank you, Dr. Ganesh. Then what constitutes the etiology or the cause of epilepsy in the elderly? This itself is an intriguing topic. Professor Vengamma, madam, what are the common etiological causes of epilepsy in the elderly?
The epilepsy could be in elderly could be new onset epilepsy. There, unlike in adults and children, the symptomatic or secondary causes of epilepsy are very high. The commonest being the stroke. Next is the dementia. The third one is any head injuries or any other neoplasms, like it could be primary or secondary neoplasms. And here the component of idiopathic or non-specified cause may be 20 to 30%. That's why there are definitely underlying cause, which helps. Also, to know the cause is definitely helpful even in the management of epilepsy. That's why we should thoroughly investigate in all patients of epilepsy in elderly.
Thank you, madam. Now, some neurological disorders like dementia, stroke are pretty much common in the elderly. And it would be interesting to know what would be the burden of epilepsy in elderly with dementia. Dr. Nandagopal.
Okay. Can you hear me?
Yeah.
Yeah. Okay. So, like coming to the cognitive disorders such as dementia, the neurocognitive syndromes, like in dementia, like the occurrence of seizure could be as high as 10 to 20%. And in patients with seizures, new onset seizures in the elderly, dementia could constitute 9 to 17% of cases of seizures. And it appears there could be a bi-directional relationship. Like, so if you have dementia, that you could have a sorry, you should not have, but if somebody has dementia, they could have a 2 to 3-fold increase in the occurrence of seizures. Or if they have seizures in the elderly, like new onset seizures, then there could be a similarly 2 to 3-fold increase in the occurrence of dementia. These are from epidemiological studies such as the Framingham Heart Study and also the atherosclerosis risk in the community ERIC studies. Like and in some instances, like as I mentioned, you could have something called the amyloid spell. Like this is more common in patients with Alzheimer's disease, where there is a deposition of amyloid in the substance of the brain, and sometimes you could have amyloid deposition in the blood vessels. And in such instances, you could get something called the amyloid spells. Some of these could closely mimic like seizures. These could be because of paroxysmal depolarization shift, or maybe cortical spreading depression or depolarization. So this is in short about.
Thank you, sir. Moving on to Dr. Naveen Prasad. Stroke in the elderly is pretty much a common clinical condition. In elderly patients with stroke, what would be the burden of epilepsy?
Sir, am I audible, sir?
Yes, you are audible.
Yes, sir. The stroke and epilepsy also has a bidirectional relationship. Patients with late onset seizures has 3-fold increased risk of stroke in their lifetime. And patients who has experienced stroke has 10% chances of developing seizures within the 5 years. And based on the time frame from the onset of stroke to seizures, they are classified into early onset seizures. Say the onset of seizures within the 2 weeks from the onset of stroke are labeled as early onset seizures, and those with late onset developing seizures after 2 weeks of onset of stroke are labeled as late onset post-stroke seizures. These patients with late onset post-stroke seizures, they are at high risk of developing epilepsy when compared to the early onset post-stroke seizures. In this way, the presence elderly patients presenting with seizures, they present a window of opportunity to screen for other vascular risk factors which they are having, and in this way they can be instituted on appropriate stroke preventive strategies based on their risk factors. So it is a good opportunity to prevent a stroke when an elderly patient presents with seizures to us.
Thank you, Dr. Naveen. Moving on to Dr. Ganesh, as a psychiatrist, what do you consider would constitute the differential diagnosis of the epilepsy in the elderly? A quick take, please.
Yes, sir. From the psychiatric perspective, sir, if you look at the etiology perspective from the psychiatry, why the patient is getting seizures, so I would like to broadly divide into two categories which contributes to the seizures. For one is like drugs, could be licit or illicit drugs. Second is psychotropic medications. Drugs, illicit drugs are alcohol and benzodiazepines. Most commonly alcohol can trigger a seizure, or excessive dose of alcohol or toxicity withdrawals may lead to withdrawal seizures, and as well as benzodiazepines also leads to withdrawal symptoms which present as epilepsy. So apart from that, there are illicit drugs which cause seizures, like opioid overdose, like heroin overdose, or cocaine, amphetamines, and stimulants, and stimulants like amphetamines. And the other thing is like we use this recently synthetic cannabinoids. We use this the FDA approved synthetic cannabinoids used in Dravet syndrome, like Lennox-Gastaut syndrome. But however, in adults, it produces seizures. Over the toxicity of this produces seizures. And coming to the psychotropics, there are multiple psychotropics which produce the seizures, like most common early, like old generation antipsychotics and newer generation antipsychotics like clozapine and bupropion, antidepressant. And the most important is tramadol. We routinely prescribe tramadol or tapentadol in our practice to control the pain, which cause seizures, which is not dose dependent.
Thank you, Dr. Ganesh. Dr. Manisha, when an elderly subject presents with seizure, which is of new onset, it's a worrisome condition. What comes to your mind?
It has already been mentioned and answered by the previous panelists, new onset epilepsy is the occurrence of or a diagnosis of epilepsy after the age of 65 years. The most common cause is of epilepsy or convulsions is stroke in the elderly. The risk factors for development of epilepsy in patients with stroke are that is hemorrhage, or people who have large infarct, or people with recurrent stroke are also at the risk of developing new onset epilepsy. And the second most common cause is dementia. Dementia is the epilepsy is more common with Alzheimer's dementia, which accounts for 9 to 16% of the cases. And the risk is higher if the dementia onset is at a younger age, or if the dementia is severe. Then the next most common is the head injury, and also the risk increases with intracranial, if there is an intracranial hemorrhage, loss of consciousness, or fracture. And the other causes include neoplasms or arteriovenous malformations. However, there are 20 to 30% of cases which are grouped as cryptogenic, where there is no obvious cause found after complete evaluation. But however, it is assumed to be stroke because those patients had risk factors to develop stroke. So these are the usual causes, most common causes to develop epilepsy in the elderly. Stroke accounts for almost half of the cases. Thank you.
Thank you. The treatment of epilepsy is a challenge. Professor Vengamma, madam, what are the treatment goals when you treat epilepsy in the elderly?
Patients with like provoked seizures secondary to underlying metabolic or those things need to be treated for underlying cause, and they may not need much long-term anti-epileptic drugs. But in other conditions like unprovoked seizures, usually they in our adult and children, sometimes a single seizure, there is a debate whether to start or not to start on treatment. But in elderly, because the chances of seizure recurrence is high because of underlying structural lesion, even if it is a single proven seizure, after excluding the non-seizure mimics, once it is a definite single seizure, we have to start on anti-epileptic drugs. The point of starting of drugs is usually you start at a low dose and build up gradually, and ideally it is a monotherapy. And because these people will have a cognitive side effects, better to be preferred on single or 2 doses, not multiple doses, or multiple drugs also. Because multiple drugs, better to avoid polytherapy, because these patients would have already had a lot of comorbids with so much of co-medications. That's why preferable monotherapy, and then with like least effective dose of the lowest dose that could be effective, as well as to avoid the side effects and the drug-to-drug interaction. Single drug with a specific dose of this one and specific anti-epileptic drug. Before starting, we should always keep in mind the associated comorbidity, co-medication, and drug-drug interaction here.
Thank you, madam. As we are chasing the Indian standard time, not the Indian stretchable time, we request our panelists to hit the message straight away. Dr. Manisha, preferred anti-epileptic drugs in the elderly. Why?
As said by Professor Vengamma, the choice of anti-epileptic drug is individualized, and the lowest effective monotherapy is a dose of monotherapy is the preferred treatment regimen. I would prefer the newer drugs which include levetiracetam, gabapentin, and lamotrigine because of the lesser adverse drug reactions when compared to the older drugs, which are phenytoin and phenobarbital. And also the drug-drug interaction because of the newer drugs is lesser when compared to the older drugs. So and also the choice of drugs is individualized. We should choose those drugs which are cognitively neutral because most of the drugs can have side effects. That is, they have drowsiness, they might have cognitive dysfunction, they might have mood changes, behavioral changes in a previous background history of any brain dysfunction. So we should cautiously choose a drug which has lesser adverse effects and also which has a lesser drug-drug interaction. Thank you.
Thank you, Dr. Manisha. Dr. Naveen Prasad, rapid fire question for you. Important drug-drug interactions between anti-epileptic drugs and other drugs, and what are the important side effects of the anti-epileptic drugs in the elderly?
Am I audible, sir?
Yeah.
Yes. So I would like to answer this question in two parts. The first part is drug-drug interaction. I'll just go briefly on it. Like based on the drug-drug interaction is considered, anti-seizure medications are divided into two categories. The first category is the kind of drugs that will increase the metabolism or excretion of the other drugs when taken together. These are like enzyme inducers, older generation drugs like epitine, carbamazepine, and phenobarbital. They will reduce, they will easily excrete the other drugs from the blood and results in the inefficiency of the other drug taken for a particular condition. The other category of anti-seizure medication are the enzyme inhibitors, are the drugs which inhibit the excretion of other drugs when taken along with the other medication. This prototype of it is a valproic acid. These sort of drugs can result in excessive toxicity of other drugs at a normal therapeutic doses. These are the two important interactions that one has to consider. But the good thing is that all the the new generation anti-seizure medications are mostly free of this drug-drug interaction. Coming to the second part of the question, that many of the side effects are dealt by the previous speakers. I would like to strike upon the side effects of anti-seizure medication on bone health, especially in elderly. The first generation enzyme inducers, in that case, this inhibitor valproic acid, are known to increase the bone metabolism and decrease the bone mass and leading to the fractures following trivial falls. But most of the new generation anti-epileptic drugs, they lack this side effect, and most of them newer drugs, the data is also lacking, sir. So most of the newer generation comes with less effect on their on the bone health of the patients. So with this,
Thank you. Thank you, Dr. Naveen. It's very well put across. Dr. Nandagopal, sir, how long do you treat epilepsy? What is the stopping rule?
Can you hear me?
Yes, sir. How long do you treat epilepsy in the elderly?
Yeah.
And what is
Okay.
the stopping rule?
To cut to the chase, like one size that does not fit all. The general principles of tapering or discontinuing anticonvulsants in elderly includes the following. First is, what is the risk of seizure recurrence in that subject following the tapering or cessation of medication. Second is the severity of the seizure. And the third thing is risk for self-injury and also the underlying etiology. For patients with acute symptomatic seizures or the early seizures in the setting of stroke and other conditions, the practice varies. The duration of treatment may range from few weeks to few months like that. In certain instances, for example, in cerebral synovenous thrombosis and all, when there is no potential for recurrent CVTs and all, so one may treat for 3 to 6 months or so, ballpark. And sometimes in like cysticercosis, and the people may treat for 6 months and all, unless there is a residual calcification giving rise to seizure recurrence like that. In the setting of remote symptomatic seizure, the duration may be longer. How long is longer? it's difficult to answer straight away. So we may need to individualize the treatment. Sometimes they may need longer duration of treatment. And in certain subset of patients, that is the patients who are fit-free for 2 to 3 years, who don't have any underlying remote brain lesions or prior brain lesions in the imaging, and whose EEG does not show any focal or generalized epileptiform discharges in the interinteral EEG. And then these patients could be cautiously subjected to tapering of anticonvulsant. And during the tapering period, we need to caution the patient. It's better not to drive, not to go to heights, and not to work with sharp tools, and to avoid sleep deprivation, fasting, etc.
Thank you, sir. It's time to wrap up this session today. Dr. Ganesh, from the comprehensive psychiatric evaluation point of view, what is your take-home message for the management of epilepsy in the elderly? Rapid fire answer, please.
Epilepsy, 20 to 50% are associated. Mood disorders, 20 to 40% are anxiety disorders. There will be personality changes, cognitive deficits. We should be very careful about these things. And also we should be very careful out there. There are chances that they may get into suicidal thoughts because of stigma, discrimination of epilepsy. And regarding treatment part, we have good medicines, newer SSRIs and anti-epileptics. The cherry on the cake is that anticonvulsants act as mood stabilizers, and we have to be careful to prevent the, to take the preventive measures like avoid insomnia, stress, and alcohol, and all these things. And also we should be careful about we should be carefully evaluate the psychological burden is imposed by the patient due to this illness. So that is also important. My take-home message is like when we are evaluating and giving the treatment of epilepsy patient, we should consider comorbidity. And it is important to not only consider seizure-free state, it is also important to approach holistically. I mean, neurological, psychological, psychosocial care in terms of, improve the quality of life and good care of the health of the patient.
Thank you, Dr. Ganesh. Dr. Manisha, quick take-home message.
As mentioned earlier, there are various causes which make the elderly, older adults prone to develop epilepsy. And also the presentation is atypical, that because they might have confusion, delirium, they might have drowsiness, and not so infrequent motor features. And the metabolic causes should also be considered before during evaluation. And the prognosis and seizure control is the same as in elderly as well as in the older adults. However, the choice of anti-epileptic drugs has to be individualized. Thank you.
Thank you, Dr. Manisha. Dr. Nandagopal is not only a well-known neurologist, he is a poet and an artist as well. Sir, your take-home message in the form of a poem or a literary piece, please.
If you permit me, let me just share
Sure, sir.
a few this thing, like or can you share the thing I sent you? Like I'm struggling.
Yes, I can share, sir.
Yeah. Yeah, I got it, I think. Right?
Yeah.
Can you see?
No.
No.
Yeah, now we are seeing. Yeah.
Okay. You can see now?
It says started share. Yeah, now we are seeing. Yes, sir.
Okay, so just I wrote a piece for this session today. Can you hear me?
Yes, sir.
Yes.
Okay, let me be fast. I thought the audience would consist of some patients or caregiver also. So just I wrote a small piece. Be an informed patient. Fix our problems in the brain. This is the message you should gain. It is the network that is at fault. Let us deposit this in our cranial vault. No more views of possession by devil. No more resort to black evil, I mean the black magic. No more clutching of iron key, but with modern eyes, we should see. Beware of the triggers, lack of sleep, fasting, fever, drugs, including alcohol, substance abuse, medication that could reduce, lower the seizure threshold, stress and weep, emotion. Avoid all this in sharpened tool with caution at the heel of fire, car, and pool, the swimming pool. In good dose, good time, take your pills so that again you don't fall ill. And just for the caregiver, those guys who have a lot of sufferings day in, day out. So this is my small piece of recognition of the problem. So
Thank you,
So,
Dr. Nandagopal.
yeah, so this is like in the lyrics, like, so it sounds something like the la 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 la. If life is a credit card just to swipe and spend days caring for ailing kin, protect your code of wealth, else screen will wipe your transactions out for invalid pin. Thank you.
Thank you, Dr. Nandagopal, sir. Dr. Naveen, could you quickly give your take-home message, please?
Am I audible, sir?
Yes, boss, you are audible.
Yes, sir. The epilepsy, when it comes to epilepsy in elderly, clinical examination, history are important. At the same time, investigating them thoroughly with laboratory and imaging also holds good in establishing underlying etiological diagnosis. And the therapy treatment of epilepsy may vary depending upon the underlying etiology. This is my take-home message.
Thank you. Madam, finally, please wrap up the session for an hour or so. We have deliberated upon the various aspects of epilepsy in the elderly. Please summarize and give us the take-home message for implementation in our daily lives.
Thank you, Dr. Mohan and other panelists of today's session. I think we have fairly covered comprehensively all aspects related to epilepsy in elderly, starting from epidemiology, diagnostic dilemma, diagnosis, as well as the other associated comorbidities and etiologies and management as well. I think we have covered, and I really thank all of them. Now maybe we'll open up for there are some questions in the chat box, Mohan, you see, and meantime, any other senior faculty can throw some light from our governing council members. Anybody can just have some light on some of the issues. I think we have covered most of it, but lack of time, some would have missed it. Dr. Gagandeep, you want to say something?
No, I completely agree. It has been really comprehensive and particularly elderly. I mean, I am not sure how is it in Tirupati, at least. I mean, I think it is a largely ignored area. It is something that people with epilepsy, elderly people with epilepsy just don't land in the clinics, whereas they are the ones who probably need to come more often to clinics because of various reasons which have been already highlighted by the esteemed panelists, including drug interactions. There are multiple medicines and they keep these medicines keep interfering with the action of other medications. So there are a number of reasons, and these people are probably more sensitive to the effects as well as the side effects of the anti-epilepsy medicines. So these are multiple reasons why we should be really aware and cognizant about the occurrence of seizures and epilepsy in older people. But sadly, I see that it is often ignored, and we generally don't see enough epilepsy patients, elderly people or older people with epilepsy in the clinics as compared to younger people. Whereas if you go by, the U-shaped curve of the incidence and prevalence of epilepsy, there have to be probably many more, we ought to be seeing many more older people with epilepsy. I mean, that's a personal observation. Which I think.
Dr. Manjari Tripathi, for any comments?
Yeah, so basically, my final comments would be that one has to have a high index of suspicion. Is it a seizure or is it something else? because in the elderly, you can have syncope, you can have cardiac events, which can masquerade and mimic a seizure-like event, or you can have a seizure which can masquerade any other event. And in particular, when there are comorbidities like diabetes, when they are hypoglycemic, when their oral intake is limited, there's hyponatremia, and of course, the issue of drugs, which is so rampant, like tramadol, etc., which really can precipitate and provoke seizures. What is important is that once we diagnose epilepsy and start the medicine, we have to caution them for falls, because if the seizures are not controlled or they do not adhere to their medicines, there can be falls, and we know that the elderly have brittle bones and there can be fractures, and we know that an 80-year-old who fractures or dislocates a hip is going to be bedbound, and from there it's going to be downhill. So really you have to be much, much more cautious than the general, younger people with epilepsy when it's coming to falls and fractures. Otherwise, everything has been wonderfully covered. And, we are going to see an exponential rise of people with epilepsy in the elderly, as elderly are thankfully living longer and longer due to better medical health care. Thank you.
Dr. Pravinasha, ma'am.
I think it's been extremely well covered, Vengamma, everything. And
Yes.
and I think sometimes we have to be very careful for the dosage in elderly, those who have got kidney functions affected. And I think there, one has to be extremely careful about the dosage, because as his kidney functions go up, they go down rather, maybe the dosage needs to be changed. That's all I have observed at times. Thank you very much, Vengamma. Extremely well
Thank you,
covered
ma'am.
by your team. Extremely well.
Thank you. Dr. Mahindra, please offer your suggestions. Dr. Satish Chandra is there in the panel, or Dr. Mahindra, any one of them? If they are not there, Mohan, you
Yeah. Madam, there
can
are
just
two interesting questions in the chat box.
can ask.
One is regarding in the present situation, elderly live alone and they are deprived of affection from their offspring and they have depressive symptoms. The question was how frequently one sees pseudo seizures in the elderly.
I think the psychiatrist can answer after that.
Dr. Ganesh?
Yes, sir. Sir, as I said, this is rare, but as a question, mentioned in the question mentioned that sons and daughters are away from them. So most of the time they don't bring to the psychiatrist. They think that they are, they are acting or they are doing something, so they don't bring to the psychiatrist. Even I have seen not the functional neurological disease, but motor movement disorders I have seen, sir. But they are present, but it's a rare condition.
Thank you. The other question is regarding what are the clinical clues in differentiating limb shaking TIA and seizures in elderly in the casualty or the emergency room setting where the attendants are very anxious about the diagnosis. Madam.
Dr. Nandagopal.
Okay, thank you for this question. One of the useful clue is the precipitation by change in posture. So the person is okay when they're lying, and when they get up, they get these disturbances because of the hemodynamic effect. So they have a tight carotid. They have a high-grade carotid stenosis, usually in the neck and all. And so when they get up, the perfusion to the brain suffers, and that's how they get this limb shaking TIA and all. So if you are in, you could do the routine investigation, because as we saw, the most common cause of new onset seizure in elderly is stroke. So it's good to work up for that. And also, if you doubt, you could do a EEG as well.
So one more clinical clue.
Yeah.
Sir. One more clinical clue is that it usually the most common differential diagnosis for limb shaking TIA is a focal seizure, and focal seizure has a Jacksonian march which is missing in the limb shaking TIA. This is one of the important clinical clue.
There is another interesting question on the use of muscle supplementation. What is that? Protein supplementation powders for muscle building and the occurrence of psychiatric disorders and seizures. Is there any tangible association? One of the participants has posed this question. Maybe
Yes.
Dr. Nandagopal, Dr. Ganesh, would you like to throw some?
Yes, sir. Okay.
Yeah, if I can just quickly answer this, like I've seen a patient actually, he was athletic, like he was lifting heavy weights and all, and he was participating in the weightlifting exercises for the country and all when he was abroad. So this guy took only one dose of this, some powder or injection or some sort of, it contains, I think, insulin-like growth factor or something. And he was put on a high protein diet, less carbohydrate, that kind of situation. So he developed hypoglycemia. He had only one seizure. But guess what? Like his life was terrible after that. Like he developed a bad shoulder dislocation and fracture actually. After that, he couldn't even lift the limb actually. So his career got ruined actually. So we should be very careful, educating people about this kind of approach. So the age-old grandma advice holds good. So stick to a good lifestyle. Like don't touch these substances. Like okay.
Thank you, sir.
Yes, sir.
Dr. Ganesh.
Yes, sir. So just add a note on that, sir. This culture is like, it's growing hugely, and everybody is trying to build the muscle. So one important thing to know that they sell this kind of blood thin fat burners, and fat burners. This is a very important term. They try to use this. Other complications, as sir that said, that osteoporosis and kidney diseases are common in these people. That's why they get fractures easily, and sometimes they may get addicted to that. They may go into extra mile, that they take caffeine and other stimulants to build the body. So it's not advisable per se.
Yeah, there are one remark by Professor Katyarmal from medicine with regard to the EEG with video. This has been highlighted during the panel discussion, sir. And also the duration of treatment was one of the issues raised in the chat box. This has also been covered. And there was a remark with regard to the effect of levetiracetam on cognitive function. And somebody posted, Dr. Madhav Rao has posted that he would prefer sodium valproate. Any take on this, madam?
I think sodium valproate also is known to definitely cause cognitive, especially in children with epilepsy. In pregnancy, studies have proven that it has got a significant cognitive effect. After two, the ideal drug in the current scenario is levetiracetam is definitely preferred over sodium valproate in elderly.
Yeah, also, sodium valproate in elderly is known to cause Parkinsonian features of Parkinsonism. They can be tremors and there can be extreme slowness. And very often, even with normal valproate levels, they can have increased ammonia levels. So, you have to use it with caution. And if you have to, you're not certain of the seizure type, you go with an extremely small dose, like 200 BD or something like that. As it is in a general principle, in elderly, you would give a lesser dose as compared to a young adult.
Yeah, just to add one more thing, like especially the combination of valproate and topiramate is notorious to cause hyperammonemia. So we should be aware of that as well. Thank you.
Yeah. So I think this panel discussion and the discussion with the participants has gone on very well. And I would conclude this presentation today by quoting a verse from the Kena Upanishad, which reads as follows: Naham manye suvedeti nona vedeti vedacha yo nastad veda tad veda nona vedeti vedacha. It is translated as follows, quote, I think not that I know it well, and yet I know that it is not unknown to me. He of us who knows it knows that he knows that it is not unknown to him. The topic is intriguing. The debate is endless. The data are continuously pouring in. and we learn as we move on. It has been a wonderful evening and a very good learning opportunity. I thank all the panelists, the esteemed governing council members of the IEA and the IES, and above all, the enthusiastic participation from the audience. I'm sure this would be a feast to the learning mind. Thank you, Professor Vengamma, madam, and you can conclude this with your concluding remarks.
No, actually, like epilepsy in elderly, even the clinical trials, because they exclude elderly people as well as the pregnancy and extreme children. That's why the data sometimes may be difficult. I think only with the adding them and with the repeated research and repeated clinical patients trying on this only, we can learn a lot of things. I think it's would have been a good, wonderful session. If Dr. Satish Chandra, Dr. Manmohan Mahendra Datta is there, I request them to speak, and otherwise Dr. Gagandeep, you can close it off. Gagandeep.
Okay. Thank you so much. Thank you, Dr. Vengamma and the entire team. Dr. Aladi Mohan, you've been fantastic. I mean, it's very well said. Your quote was really very well appreciated. Thank you so much. And you've really conducted it really nicely. So thank you so much. It's been a great pleasure to meet all the panelists. Dr. Nandgopal, you're not only an astute neurologist and a clinician, which is clearly evident by the discussions that you made, but you're the other part is also very enchanting, and we really loved it. So your poetry and you can sing very well too. So fantastic. Thank you so much for such an interesting and wonderful. Dr. Manisha, Dr. Dr. Naveen and Dr. Ganesh, right? So thank you so much. We've had a wonderful time.
Manisha is my daughter.
I know. Yeah, fantastic. And it's a great pleasure to learn that you are, Manisha, you are specializing in geriatrics. So that's the need of the day. And there are lots of areas where geriatrics and neurology there is a lot of intersection between the two disciplines. So all the best to you, and all the best to your for your career, for your life. Fantastic. It's been great meeting you. And of course, thank you, Dr. Vengamma, madam. Thank you for this, actually for choosing this topic, because it's something which is often not discussed, but it probably needs much more discussion. So I'm extremely grateful on behalf of the entire Indian Epilepsy Association and the Indian Epilepsy Society for taking up this important topic. Till we meet again next month, third Sunday, around the same time, 5 p.m. Thank you so much.
Anybody who is next month, any idea?
Jaipur, sorry, not Jaipur. Cochin people, sorry.
Cochin, okay. Anyway, thank you, Dr. Gagandeep, for staying till the end, and it's very nice program. And stay safe. And I think now COVID has come down. I think all of us are. This one
we are looking forward to the meeting.
Physical meeting of IEA. I think we can discuss later. And thank you for everybody who is actively participated till the end of the program. Thank you once again for giving us this opportunity to host today's webinar, 7th webinar. We look forward for the 8th one. Thank you.
Thank you so much.